So we have about 20 people here already. I think we can actually start. So for those of y'all that I may not have met before, my name is Ben. I'm from GenMed. And today we'll actually be doing this session a little bit differently from the usual. So as I think most of y'all might be aware, this German has been running this referrology series, which by the way, if you guys haven't checked out some of the episodes, please go in and do that. And because Jermin told me he does not want to do the please subscribe to my channel thing, so I will do it for him. Please subscribe to his channel, and there's a lot of very good information down there. So it's very nice. I think it's one of the things that has come out of this COVID situation. All the information is just there. So a lot of very useful practice pointers there. And how we thought we'd do this is also in a similar way, so that it can be a little bit more interactive since it's over Zoom. So maybe to start the session, I'll just hand over to Jeremy.
Okay, so yeah. So hi everyone. So I think along the way, if you have any questions, just feel free to post in the chat group lah. So then I can also ask them along the way. So anyway, yeah. So let's start. Okay. So today, Ben, read the next slide. Yeah. Okay. So we'll talk about this this case scenario. So Madam T is an 84-year-old Chinese lady with advanced Parkinson's disease. She's bedbound, uncommunicative, and NG-fed, and comes in with recurrent admissions for pneumonia with no prior documented discussions on goals of care. So I think many of us are quite familiar with such patients that we do see in the general medicine setting. Maybe next slide. So Madam T is admitted for fever this time around with some shortness of breath, is hypoxemic on presentation and placed on NRM. So the X-ray shows bilateral pneumonia, and in NUH, we sign off the care form, first 4 boxes, and she started on IV augmentin. The family understands that the prognosis is guarded and wants her to be comfortable, but they are still kind of hopeful that she can turn around. So, so Ben, can I, maybe next slide, yeah, can I find out how we should approach the prognostication of such patients when they come into us?
Right. So this is a very common scenario that I think all of us will face many times, maybe even in a single call. And one of the big challenges that we find in dealing with patients like that is these patients do not come with a set life-limiting condition like a particular cancer at a particular stage. They also do not have a certainty about how even this episode of the illness is going to turn out for them. And that makes it very, very challenging to prognosticate from our point of view. And sometimes that leads to a bit of a challenge in terms of the type of care that they receive as well. So one of the things that we do and we focus on a lot in GenMed is dealing with this level of uncertainty in seeing the patients that come to our wards and things like that, right? And so the first thing that we wanted to bring across is in a patient without a clear-cut life-limiting condition, where you look at them and you say that, yeah, they look pretty sick. It certainly can get worse from here, and in all likelihood, you would have told the family that things could take a turn for the worse. Many of us here may have heard of this thing called the surprise question, right? So the surprise question, for those of us who may not have come across, is something like this that was aiming to deal with some level of uncertainty. And it was actually used as a trigger for us to think about advanced care planning, right, ACP. And the surprise question, just quite simply, is to ask yourself, would you be surprised if this patient were to pass away or to die in the next 1 year, right? And answering a no to that question, that means I would not be surprised, is supposed to trigger a different kind of thinking and a certain kind of conversation to initiate with the patient. And usually that is a type of conversation that is like advanced care planning, right? So the first thing that I want to bring across when we're dealing with the inpatient setting and a patient who's very sick like this, I like to propose that we can ask a different kind of surprise question, right? And this is, as what the thing says here, would you be surprised if the patient died during this admission? And once again, I think this is something that should trigger a different kind of approach in our management of the patient, and a different kind of conversations with the family. And we're going to talk a little bit more about that as this session goes on, right?
Okay, thanks, Ben. Maybe you can bring us to the next slide. So the surprise question provides us a bit of a framework to think about how the patient may overall be doing. But I think a practical question or challenge that we face on the ground is that sometimes we aren't really sure which direction the patient is heading in, like whether the patient turn around, as we've oftentimes seen that some of them do, or whether the patient actually is not going to make it this admission. So in this kind of conundrum that we face, how should we approach the situation?
Right. Okay, thanks, Jermaine. So for this one, I'm not going to answer the question immediately, but I thought we'd instead ask you guys some questions so that we keep everybody involved here as well. So if I can just get everyone to scan this QR code or to use the address, this poll everywhere address up here, we're going to take this discussion to our patient, this Madam T, right? So for those of us who may have just dropped in, our patient here is Madam T, who's an 84-year-old lady. She's got advanced Parkinson's disease. She's bedbound, uncommunicative, and she's now admitted with what looks like a severe pneumonia. And the family understand that things might get worse, but they're still hopeful that she might turn around, right? So with this in mind, let's look at this and what would your overall management strategy be? So we've got a few options down here. We could say that, okay, she looks quite sick. Let's stop antibiotics and start morphine. And we just focus on comfort management. We could give a trial of antibiotics for 2 to 3 days and then start morphine if we think that the response is no good, right? And third option is talk to the family, ask them what they think about antibiotics, what they think about morphine, and act accordingly. Or we could give some antibiotics and also start morphine at the same time. Okay, great. So we've got most people selecting the last option of continuing antibiotics and start morphine at the same time for comfort, which is also pretty much the option that I would choose in this kind of setting, right? So just now the question that Jermaine had brought up was this very important question, and how do we deal with this degree of prognostic uncertainty when it comes to patients like this, right? So we know that patients like that might turn around, they may also get worse, and the question becomes, how do we do, you know, am I going to make her pneumonia worse by giving her morphine? What's the point at which I should consider taking off my antibiotics and things like that? But really what we are trying to emphasize in dealing with patients like this is this concept of parallel planning, right? And parallel planning basically means that so-called curative or definitive treatment should go hand in hand with palliative or comfort kind of directed treatment in alignment with the patient's goals of care. Right? So this is something that's pretty interesting. And here I thought that we talk about a little bit about this concept of models of care, right? So we have this old model of palliative care, right? So if you can see this at the left side of the screen, we have what we call curative care. And this basically involves things like antibiotics for pneumonia or infection, chemotherapy, radiotherapy, surgery, and things like that. And on the right side, we have palliative care, right? And this usually refers to, you know, our conventional understanding of palliative care, which is opioids for comfort, referrals to palliative related services like hospice services. And basically this diagram here shows patient care progressing along this kind of path where you start with curative care, and at a certain point where the patient is not responding, we switch over to palliative care. And after that, the patient has died here, right? So there were a few problems with this, as you can imagine. And in this old model of care, we used to think that, you know, I don't want to start the patient on morphine, and because the patient is still being treated for a pneumonia with antibiotics. So I will start the morphine once the patient is not responding and then I'm going to switch to the opioids and things like that. But there were a few problems with that, as you can imagine. And that comes to the degree of uncertainty that we're dealing with in a patient like that. Very often a patient like that, if we opted to manage along those lines, might suddenly get worse and might suddenly get a lot sicker. And we just keep asking ourselves, okay, is the patient going to recover? Is the patient going to recover? And then eventually the patient dies without all the appropriate symptomatic type of treatment that's on board, right? So here I put up this, picture of a bow tie. And I wonder whether anyone has any idea why this might be the case. This is actually one of the slides that, for those of you all who might have attended the session about a year ago, this has been updated a little bit because there is this new model of palliative care. Not so new, but I think in recent times, I think this has become more popular. And this is what we call the new bow tie model of palliative care, what they call the palliative care enhanced model, right? So you can see that instead of just palliative care, curative care stop and then palliative care takes over, here we have a continuum of so-called disease-specific care and palliative care. And they kind of overlap with each other in the continuum of a patient's journey, right? So just to bring up a few very nice things about this model and why this works so brilliantly, right? It's because you can see on this side, again, at a certain point where we are trying to cure the disease, we're trying to get the patient recovered, we start off predominantly with all this curative type of treatment, right? But as the patient gets sicker and sicker, this pain and symptom management is just as important and plays an equally big role. As you can see, it's increasing and increasing as the patient progresses along the journey. Yeah, and at a certain point, when we find that the patient may not be responding so well, that is where the disease-specific or curative treatment starts to decrease, and the palliative-related treatment starts to increase up to the patient passing on, and that's when the patient dies down here. Right? So it kind of goes in parallel, like we talked about earlier. And the nice thing about this model is that it also takes into account that not every patient gets worse, right? Especially for this group of patients like Madam T, she may really turn around like like the family was hoping for. And this also takes that into account, that patients may get better. They may go to the top part of this diagram here, and they may go into survivorship after that. Right? So that's the thinking in this bow tie model of palliative care. Okay, so we can move on after.
Okay, thanks, Ben. Thanks for providing us a big picture understanding of the different concepts and models that we can adopt. But perhaps now we can shift gears a bit. So we know that symptoms are a big part. Symptom assessment and management is a big part of palliative care. So back to Madam T, who comes in with what seems like a pneumonia. How should we be assessing for dyspnea in Madam T, given that oftentimes in these patients, they can't tell us overtly that they're breathless?
Right. So it's a very important question, and I think so. This is supposed to be a palliative care session, and of course, the question that probably would be on a lot of your minds is why we are not addressing pain first, right? And it's interesting because in my own experience on call scenarios and in the patient population that we deal with outside of the cancer group, it seems that the most frequent issue that we tend to deal with is breathlessness. And at the same time, we also find that there's a lot of literature and a lot of teaching on pain kind of treatment, sometimes not very, very much on breathlessness. And I think, so we wanted to start with assessment, because everything in the symptom management part of palliative care starts with a good symptom assessment, right? So for this one, maybe I tell you a story first, right? So, not a long story, right? So when I was doing my palliative care elective last time, in fact, this was when I was a resident. So I was going to see a breathless patient, and I was being accompanied by a consultant palliative physician. By the way, that time got more consultant palliative physicians. Okay, so anyway, I went to the patient, I went to talk to the breathless patient, and I still remember clearly that the first thing I was told was, you are speaking too fast. You're speaking too fast, so speak a little bit slower, you know. And I think that highlighted one of the very, very important parts about how breathlessness develops and how breathlessness, the experience of dyspnea from a patient's point of view. And it's very important to see breathlessness as not just a physical kind of symptom that they're experiencing, but also very much there's a very strong fear and anxiety type of element, right? So a lot of the COPD patients that, you know, we speak with and things like that, they may say that, you know, yeah, I can't get the air in enough. I can't get the air through. I feel like I'm drowning. And you can imagine that there's a very strong anxiety component with it. And so in assessing the dyspnea, the first thing that I still remember, and that has stuck with me today, is that the way in which we go and speak with the patient and the way that we assess the patient is quite important. And we need to take into account that this is going to be someone who's feeling anxious, who's feeling worried. And even the way that we communicate with them can have a very big effect on that, right? So to speak slowly, to be gentle, you know, not to be, they may be a bit hearing impaired and things like that, but even the way that we are shouting at after that, them sometimes can lead to increased anxiety levels or increased stress levels, right? So the concept of total dyspnea that has been put up here, there is a concept of total pain, which some of you guys may have heard about. And basically this is to emphasize the fact that very often it's not just the physical manifestation of dyspnea, but also the psychological, the social, and very often the spiritual kind of elements that contribute to the experience of shortness of breath in these patients, right? So a lot of times these things will need to be addressed as well. Okay, so in the assessment of dyspnea, a few things. So we usually talk about history, physical examination, and just to move quickly through, in the history taking for a patient who is alert and able to provide that, very often we of course talk about the usual symptoms that a patient might accompany the breathlessness with cough, wheezing, exacerbating factors, and a lot of times remember the impact on function as well. So very often, especially the COPD group, I find, they will not tell you that, you ask them, are you breathless? Are you breathless? They will say, they'll say, no, but you know, there will be a lot of impact on function. Can you walk to a certain place which is you know, 1 km away? And they'll probably tell you no, and I feel very breathless when I try to walk, and I don't feel breathless, but I have severely limited my activity level because of the breathlessness, right? Interestingly, apparently one of the things that COPD patients or these chronic breathless patients struggle with is showering. And showering, just because even that length of time that we take for granted when the water is going over our head and coming over our face, where we actually need to hold our breath for a moment, that becomes something that is very difficult for them to do. Right? There are actually numerical rating scales as well as categorical rating scales, which we can use to provide a more objective kind of documentation of the patient's breathlessness, right? Examination, and this is one thing that I perhaps need to emphasize this session, which I'll tell you all why a bit later. But very often we equate respiratory rate with breathlessness, right? Which is not quite the case. Remember that a patient can be breathing very shallowly, and so they can be breathing quite fast, but they're actually quite comfortable. Similarly, a patient may be actually bradypneic, breathing very, very slow, but they may be using a lot of effort, and there's a lot of accessory muscle usage and things like that, which the patient is going through. One thing to emphasize in this whole thing is to document these aspects of the assessment so that later on when people are assessing the patient, they can see how the patient is responding to treatment, right? So I wanted to emphasize this thing about the respiratory rate as well as the work of breathing, because very often we see the documentation when patients are prescribed opioids is to use the respiratory rate purely as a trigger, right? So we will write serve morphine or fentanyl if the RR is more than 24 or 26 or something like that, right? And we'll say omit if RR is less than 12. So we try not to do that. And the reason is because breathlessness is not equal to respiratory rate, right? It's all these other assessments that we will have. So what is the right thing to document in your instructions box when we order? Later we will get to that, okay? Yeah, so that's the assessment of dyspnea. Yeah, so this is I forgot this slide that I had, which is that basically we want to shift the documentation to something like that. And remember, you know, just now I mentioned that when we're assessing the patient, those that fulfill this modified surprise question, we ask ourselves, would I be surprised if the patient died this admission? If the answer is no, essentially what it means is that the focus of our daily care needs to be on the symptom assessment, you know, because this is what we should be, we know we can make it better for the patient, you know. And so even in assessing the patient, we are hoping that we will see people documenting things like this, right? So instead of just a kind of cursory going through the heart, lung, and things like that, you know, so the patient is tachypneic, using accessory muscles, you know, and looking at the relevant things for a patient like that. Yeah, so to document assessment accordingly. Yeah, okay, sorry, Johnny, back to you.
Okay, thanks, Ben. So I guess after we have assessed our patient to actually be breathless, how do we go about managing this dyspnea or breathlessness that she's experiencing?
Okay, thanks. So this part, we're going to talk through the non-pharmacological as well as the pharmacological parts of it. And very often we focus on the pharmacological while forgetting that there are quite a few things that are, you know, relatively easy to do and that can have a big impact on the patient's experience of breathlessness, right? So the positioning, so most patients who are breathless will feel better in some kind of leaning forward type position. Interestingly enough, even patients who are bed bound, like our Madam T down there, very often some people find that if they are positioned even in the bed on the side in a leaning forward position, this puts the diaphragm in a position that is becomes easier for them to breathe, and it can help with the sensation of breathlessness, right? So interestingly, a fan has been shown to be very effective in relieving a patient's breathlessness as well, more effective than, in fact, oxygen in a lot of cases. And the fan seems to activate the trigeminal receptors on the face, which helps with the subjective experience of dyspnea, right? So pharmacological, remember that treatment should still be directed at the underlying cause. If the patient is wheezing away, then of course we still use our bronchodilators and things like that. If the patient is fluid overloaded and they're still passing urine, then diuretics will be helpful. Yeah, so, and of course, aside from that, the main symptomatic type of treatment pharmacologically is opioids. And to note that usually they require lower doses than pain, right? So just now we talked a bit about the anxiety component of breathlessness. Very often I do find that benzodiazepines, especially when we can see that the patient is actually anxious, can be very helpful for the anxiolysis component of it. Right? So in this management component, I wanted to take us quickly through a bit of the literature behind this concept of opioids and respiratory depression, right? So there have actually been, you know, though the reality is that palliative studies are small. You know, we don't have huge RCTs like what we see in other disciplines, but there are a few studies, right? So there are a couple of studies that actually looked at administering doses carefully titrated to patients with chronic shortness of breath. And in a couple of these studies, they actually monitored the patient's transcutaneous CO2 levels, right? And in this study, they basically found no opioid-induced respiratory depression, no increased CO2 retention. This one was a similar one where they monitored transcutaneous PaCO2 in even opioid-naive patients, and they found no adverse reactions so long as the thing is titrated properly. This was actually a big, bigger study. looking at 83 patients. Interestingly, this one was actually mostly non-cancer. So I think the majority of these 83 patients that were seen in this study were actually COPD patients, right? And how they did it is, interestingly, they actually gave the morphine at a titrated fashion. So they started with 10 mg daily, then they went to 20 mg daily the next week, and then 30 mg daily the next week. And interestingly, there was still no respiratory depression and things like that. So usually what we emphasize is that when the morphine is titrated in an appropriate kind of manner, if it is started at the appropriate doses, then there is a very, very low risk of respiratory depression and stuff like that, even in a COPD patient, right? Because some people will say that, oh, you know, COPD, they are already retaining CO2, so I cannot give morphine, but also not true. Okay, so just to sort of put it in a bit more of the practice kind of setting. So here we have suggested doses for opioid naive patients, and morphine will be the first line for everybody because it is cheap, it is effective, it has the best kind of evidence behind it in this kind of setting. We use fentanyl when there is a good reason for it, and the good reason is typically when there is either renal impairment or liver impairment, right? So, and usually, just now we talked about, we don't want us not using the respiratory rate as the only trigger for administration. So the appropriate kind of instruction is written here, right? So for shortness of breath, and inform doctor if RR less than 12, right? So you can see that actually this is shorter than the thing that we talked about earlier. The administer if RR is more than 26, don't administer if RR is less than 12, and things like that. And so there's a reason for this, right? So you can see the problem with this instruction here is that we worry because number one, of course, you know, so I've talked to a few people and they tell me, yes, the reason why we do this is because we want to make sure that the nurses administer when the RR is high and things like that. But remember that RR high doesn't mean that the patient may be very, very breathless, right? And similarly, RR low also doesn't mean that the patient doesn't need opioids. So sometimes because of this, we see that opioids may be administered inappropriately or also may be stopped inappropriately, right? So we put instruction like this because we just say that it's for dyspnea, for shortness of breath. And I think a big piece of this will be teaching everyone, you know, from us to the nurses, how to administer this appropriately and how to assess for dyspnea appropriately. And here we write, inform doctor if RR is less than 12, right? And the reason for that, again, is because we don't want it to be stopped just like that, but we want the patient to be assessed through all those means that we talked about earlier, whether the patient is still breathless and whether the patient is still requiring that. Okay. Yeah, back to Jeremy.
Yeah, thanks, Ben. So if I may recap, I think you shared about the importance of non-pharmacological measures like positioning, the use of a fan, and also demything the respiratory depression part of things that people sometimes are maybe a bit irrationally afraid of. And thirdly, also importantly, how we document some of the order instructions so that patients appropriately get assessed. Maybe before I move on to this next question, you did mention that fentanyl should be considered in patients with, let's say, renal or hepatic impairment. Is there sort of a GFR cutoff that you use for the renal impairment to decide on fentanyl versus morphine?
No, so there anything less than 30, I would usually use fentanyl. But of course, remember that. So when we talk about liver and what do you call that? Liver and renal impairment, there isn't it's not to say morphine is contraindicated, right? But the reality is it can accumulate with repeated doses. So there isn't really a strict, especially if you're giving, you know, intermittent doses, like 1 or 2 doses, just like that, probably morphine is going to be fine. So this thing really comes when you are expecting a continued administration or the patient is receiving regular doses on an infusion. Yeah, I would be very careful. Any essentially any evidence of the crack clearance being less than 30 and things like that, I would try to switch to something else if I expected the patient to need further doses. With liver impairment, again, we don't have a direct kind of child's scoring part of it. A lot of it, so we will encounter this in different settings, right? I think if there's any evidence of cirrhosis, I think we will probably opt to use something other than morphine, again, if the patient requires more frequent doses. In the cancer setting, very often we may need to look at the extent of hepatic metastases, right? And when we see that, the liver parenchyma is getting significantly occupied by tumor or metastases, then again, this would be a sign that we might need to shift to fentanyl if a patient requires something regularly.
Got it. Okay, thanks, Ben. Okay, so the next question is, so we go back to Madam T, and let's say we have given her 1 dose of subcut morphine, 1 mg, and she still appears breathless. So what should we be doing next for her in terms of, like, should we be giving her more opioid? Should we wait 4 hours for the next dose? Could you take us through practically how we navigate this space?
Okay, yeah, thanks. So I think this part of it, we wanted to spend a little bit of time because most of the questions that we had in sending out the survey before this, and I think as Jermaine was gathering some of the common challenges that we encounter were around titrating sort of opioids and how we deal with a situation like this, right? So the first thing perhaps to emphasize is just this, right? If you have seen that Madam T is still breathless after 1 milligram of morphine, that means that you have reassessed the patient after the administration of the morphine, and that is actually already, I would say, 80% better than what most people will do, because most people will kind of just order 1 mg morphine for hourly PRN or something like that, and then maybe come back later in the afternoon, right? Yeah, but what should be happening whenever we give an opioid for breathlessness is we should reassess the patient right when we expect the dose of the opioid to peak, right? So if this was administered subcutaneously, it would be appropriate to come back in about 30 minutes to assess, right? And the reason for this is quite simple, right? When we start an opioid in someone who is opioid naive, we are going to be giving a safe dose, a low dose, right? And there is every possibility that this dose may be insufficient. And the patient may still be breathless, and they may need actually a bit more than that. So it's important to come back to use that same assessment strategy that we used earlier and compare it to before, right? So the patient was just now using a lot of the accessory muscles. How is that looking now? What was the respiratory rate before? What's the respiratory rate now, right? And in fact, the other misconception that I wanted to address is that we always order morphine, whatever dose for hourly PRN, right? And some people take this to mean that when I give 1 dose of morphine, the next time I can give a morphine is 4 hours later, right? But again, not entirely true, because the dose still needs to be given appropriately, right? So there's every likelihood that 1 mg may be insufficient. And when I assess the patient half an hour later, if the patient is still breathless, the correct thing to do is actually still to give another dose, right? Of course, you don't keep giving and giving and giving until you've given an opioid naive patient 10 mg of subcutaneous morphine, but we'll talk a little bit more about that in the next few slides, right? So I wanted to put this thing up about morphine titration this is not meant to be a protocol, right? But more an illustrative example to show you guys how opioids can be titrated in this setting when you are starting an opioid for someone who is feeling shortness of breath, or even for pain and things like that, right? So just now we talked about starting the dose at, okay, here says 1 to 2 mg, but I think in an opioid naive patient for breathlessness, 1 mg would probably be more appropriate, right? So you give 1 mg, reassess the patient in 20 to 30 minutes when you expect the dose to have kicked in and the effect to have peaked, and reassess the patient. If the patient has improved, then that's fine. If the patient has not, then go and give another dose, right? So the next part is actually this conversion to infusion, which I must mention is not something that you will do in all cases, but back to your assessment of the patient and whether you think that the breathlessness is going to be something that is ongoing, or whether you think the breathlessness is going to be something that is intermittent, right? So I could give you two scenarios, right? One is, let's say, a patient that we think is aspirating frequently. And so normally the patient is quite okay, but you know, occasionally there's a bit more secretions, there's a bit more saliva that they choke on, and then they got quite breathless intermittently. And for a patient like that, it's quite reasonable to say that you know, I expect the thing to be intermittent, and I give just PRN doses. On the other hand, in a case like this, when the patient is coming in with pneumonia, and we can see the X-ray changes, we can assess that the patient is breathless continuously, we probably do expect them to need something on an ongoing basis. And in this kind of situation, then after that, we would want to start the patient on an infusion so they get that kind of treatment on an ongoing basis, right? So the dose that I've given after we go through this loop down here is something that once I feel that the patient's symptoms are better controlled, we take this as what we call an effective dose. And because we know that morphine is given, the breakthrough is usually, the duration of action is 4 hours. Now the intention with the infusion will be to administer this dose continuously, right? So I would usually take, if let's say I give 2 mg as the effective dose, and now I want to give that continuously, I would administer a morphine infusion of about 0.5 mg per hour, right? So just to bring this to a similar thing for fentanyl, right? So let's say I'm doing fentanyl, reasonable starting dose is about 10 to 20 mics subcutaneously. And again, I reassess after 20 to 30 minutes. If the patient has improved, that's great. If the patient has not improved, I go back and give another dose. And after that, let's say I have given a total dose of 40 micrograms. For fentanyl, the duration is shorter, right? So 2 hours. So to administer this continuously, I would divide by 2. So to give a dose of 20 mics per hour, right? I see a hand raised.
Hi, Ben. Thank you very much. This is Woon Chai here.
Oh, hi, Woon Chai. Yeah, go ahead.
Hi. A word of caution. I don't think that I will actually start someone on a subcut fentanyl infusion of 20 mic per hour as a starting dose, because if you total up the dose, it's actually fairly high dose. So actually, I also, my practice is I usually also do not give subcut fentanyl 10 mic as a starting, so 10 mic as a bolus dose, because 10 mic is your oral morphine 1 milligram. To see an effect, sometimes it's very difficult to see any effect. So sometimes if you cumulatively use up to 4 doses of 40 mics for you to see an effect, it need not necessarily mean that the calculation equates to 20 mic per hour. So especially for someone with opioid who is opioid naive and who is a non-cancer case, my inclination is to start a bit lower. My usual starting dose would be fentanyl 5 mic per hour or 10 mic per hour. So for those who require a bit of a higher dose one, I think 10 mic per hour is safe. In fact, I hardly ever start anyone on 20 mic per hour straight away.
Okay, yeah, so I think, I guess this is one area that probably practice may vary a little bit. We've got, so one thing I would also emphasize is that I think this whole thing also does need to take into account. Again, we don't want to have a case that we are giving multiple doses recurrently because we feel that the patient is still breathless and things like that until the doses go to a very, very high level. So there are certain situations that I find patients will not respond very, very well to opioids. One of the settings that I found this is the case is in metabolic acidosis. So in patients who are, you know, they may have severe sepsis of some sort, and lactic acidosis, or severe kidney failure, and they may also be very, very significantly acidotic. So in this kind of setting, for that reason, there was a cap on the dose of 40 mics to administer within a certain period, as well as this is as capped on the infusion rate. So this is this is something, and actually I agree with Moonchai that if I was just starting the infusion directly like that, usually I would probably start at about 10 as well. Yeah, but I think in this kind of setting, we take it that the patient has received quite a few doses over a certain short period of time because symptoms have not been under control. So I think that was the reason why this was here. So we had the 20 mics per hour infusion here. For the morphine case, sorry, just to go behind. Also, we had a certain cap on the doses that would be started. Right. So I think, again, because you guys can see that practice may vary a little bit in terms of what we feel is appropriate in terms of the starting dose. We don't want to make this as a protocol, but if there's any part of it that should always be done, it is the reassessment, right? So that means that when we give a dose of subcutaneous opioid or even oral, for a certain symptom that we're assessing for and that we see, one of the important things is always to come back and to reassess, to document that reassessment and to show why we are administering sort of something else after that. Okay?
Yep, the next question would be, maybe we can shift gears a bit. So let's say now she's a bit more settled on the breathlessness, but she's starting to become a bit agitated. So how do we go about with the assessment and management of terminal delirium?
Okay, so in delirium, I thought we'd go back to our, this one just to keep you all awake. We'll go back to our Poll Everywhere slide. So if those of you all missed the QR code earlier, you can go to the link that's on top here. Okay, so Madam T is started on a subcutaneous morphine infusion. She looks like her breathlessness is improving, but she gets increasingly restless and agitated. You would start NG quetiapine. She has an NG tube. Subcutaneous haloperidol, subcut midazolam, or physical examination and a digital rectal exam. Okay, I'm going to move us on because in the interest of time. Okay, great. So physical examination and digital rectal exam is correct. And this is just to emphasize one part of it, right? Which is that every time we assess that a patient is delirious, just like in a non-palliative type scenario where we need to assess what is the cause for the delirium, right? We need to assess for reversible causes first. And this is not to say in all cases there's going to be something reversible that we find, but very often we're dealing with just very simple things like pain, constipation, urinary retention, and things like that, right? So a patient on opioids, for example, could well be very, very fecally loaded, and they could, have a massive palpable bladder and things like that. But otherwise, if in the sort of terminal delirium type setting, usually the preferred choice is subcut haloperidol 1 mg 6-hourly PRN. Benzodiazepines are usually not preferred as a first line kind of thing. And the reason for that is because in some cases, they can cause a bit of paradoxical agitation, right? Okay, so again, in the management part of it, we have non-pharmacological and pharmacological. A lot of the management principles similar to the non-end-of-life kind of setting. So have familiar faces at the bedside, regular reorientation, avoiding restraints as far as possible, especially given in cases like that, given the overall goals, right? And pharmacological, we've mentioned haloperidol. And midazolam, if at all, is given, usually that will be lower down as a second-line agent.
Thanks, Ben. So next, maybe we can talk about how we go about with the management of secretions and noisy breathing.
Right. So I think all of us, I think by now are aware that in the pharmacological management we use buscopan or hyoscine, right, in the end of life setting to manage secretions or rattle. Right, and maybe just to emphasize, in case some of us may not be aware, that the dosing is different for the buscopan dosage that we use for abdominal cramps, right? So not 10 milligrams, but usually 20 milligrams and 6-hourly PRN, right? So I think one thing to emphasize on the non-pharmacological end, I think this is one of the elements that often we have to cooperate a little bit and talk a bit with our nursing colleagues on this. And sometimes the goals of care even from the secretions management point of view, do need to be well communicated within the whole care team, right? I usually tell people there is an active way of managing secretions, and there is also a way that is focused on comfort, right? The active way, and those are for cases that, you know, we think, we're still trying to clear the secretions basically actively, and that is where we will use things like Flumucil, aggressive chest physiotherapy, suctioning, and things like that. But you can imagine that although these things are the proper way of doing it, you know, in a patient that we're trying to get all the secretions out, you know, get the patient better and things like that, they can be quite uncomfortable for the patient. You know, the chest physio, if you're whacking them all over the chest, or the suction catheter, if it's stuck very deep into the throat, can be all quite incongruent with the goals of care in the palliative type of setting in the end of life, right? So in cases like that, suctioning, if it is done, should be just very gentle oral type of suctioning, oral hygiene, and also using the Buscopan or the hyoscine to treat the secretions part of it, which is usually very effective. In a lot of cases, we do speak with the patient's family if they are bothered with this. And we do know that noisy breathing, and the secretions and the rattle are often more troubling to the caregivers than to the patient themselves. Because by this stage, they are usually very, very drowsy, and they are not struggling a whole lot with that per se, right? The flip side to this whole active versus comfort management of secretions is that we also try to avoid Buscopan in the non-terminal type of setting, right? And the reason for this is because if we were to give Buscopan in that kind of setting, what often happens is that the secretions become very, very thick and insipated, and patients can mucus plug after that. So it's not the ideal kind of secretions management in the non-end of life setting. So we should try to avoid that as well, especially repeated doses. Okay.
Okay, thanks, Ben. So I think the next question would be, how do we convert between different opioid agents? So I think one of the common scenarios we face, because tramadol is one of the agents that many people reach too early, and let's say we max out at, let's say, 50 TDS or even higher doses, and we need to transit to, let's say, morphine. How do we go about practically doing so?
Okay, right. Okay, thanks, Jermaine. So very quickly, I'm going to put up the opioid conversion chart down here. And so this is something that I think all of us, some of us may have seen at some point. I think just to emphasize that when we're converting between opioids, number one, it assumes that the patient's pain control is okay on that particular dose. And the second thing to emphasize is that we always calculate using the total daily dose, right? So because, for example, you know, if we are comparing between morphine and fentanyl, for example, so fentanyl is something that if we are giving sort of repeated doses, it's administered every 2 hours. Morphine would be every 4 hours. So to convert between those two sometimes becomes a bit confusing if we think about single doses. So when we're converting, we use the total daily dose, right? So everything also goes through oral morphine as a kind of like, everything basically goes through the calculation of oral morphine, right? So if we're trying to convert from oxycodone to parenteral morphine, we will go convert to oral morphine first as an equivalent kind of thing, and then after that go to the morphine here, right? So I think just to illustrate these concepts, because in practice, I think nowadays there's very little need to go and look at this diagram down here and you know, try to puzzle over this. I think just to bring up one of the resources as well that is available to us now, if you guys can go on your phones to this and Google this SGPAL ebook, right? So this was a very nice thing that was put up, and it's a local thing. So the doses and, you know, the types of opioids that are put up down there are all what is locally practiced, right? So in fact, it's not just the opioid calculator. There's a bunch of nice resources down here on symptom management, local palliative care services, even terminal discharge resources as well. But maybe terminal discharge, I think our own intranet resource is better. So I think I'll use that, right? And at the bottom of it, basically, there's a nice opioid calculator that is quite easy to use. So if I can get everyone to maybe maybe just Google the SGPEL ebook now, because the next one is going to be a mini exercise of sorts, which let's try and do over about 2 to 3 minutes. Okay, so Madam S, so different patient this time, has breast cancer, pain from bone metastasis, well controlled on tramadol 50 mg TDS. So she finds it difficult to swallow pills. She's also found to have worsening liver function from metastasis. And how would you proceed? Okay, so in the interest of time, let's move on. I see a couple of responses down here. So I think converting to fentanyl is right, because of the liver impairment in this kind of setting. So, and of course, she's also finding it difficult to swallow pills. Yeah, so this is a little bit, of course, yeah, I'm seeing some more responses down here coming. Maybe I didn't wait long enough. Okay, so maybe just to illustrate, if we go to the, so converting to fentanyl is right because of the liver impairment in this kind of scenario. And if we just try the SGPEL ebook thing, right? I don't know whether you guys managed to try it just now, and we put in the doses of tramadol that the patient is currently receiving. So tramadol, again, we should go by the total daily dose, right? So we will use, in this case, tramadol of 150 milligrams. So, and if we input the thing down here, so quite easy, right? So tramadol, okay, I'm doing it just to make sure I don't remember don't tell you all the wrong thing. So if we convert to fentanyl, yeah, so we get 12.5 micrograms per hour, right? So it would be reasonable, so depending on the clinical scenario, starting an infusion would be reasonable, and maybe eventually using a patch as well. Maybe just so 10 micrograms per hour would be reasonable. If we were using a patch, probably just to emphasize a couple of things. The patch, the lowest kind of unit that we can give is usually a 12 mics per hour infusion. Some people do this off-label halving of the 12 mics per hour patch, but that's supposed to be off-label, so it becomes a 6 mics per hour kind of thing. So a 12 mics per hour patch would be reasonable. The patch does take about 12 hours to work because it needs to form a subcutaneous depot to work. While that is happening, by right, the patient still should be on something else, which can be administered subcutaneously or via infusion or something like that. Okay. Okay, I think I've got the last few slides. Okay, I'll just be about 5 more minutes. So we wanted to end off with a little bit of some of the resources that are available, because you can see that what we can cover in a session like that is rather limited. So a few things aside from the SGPEL ebook, which we've brought up earlier. So our own intranet page has a lot of very good stuff down here as well. So in case you guys may not be aware, if you go to the usual your CDoc and you go to the references tab on top, there will be a palliative care section there, and that will launch this intranet page here, right? So in case you might not be able to find this from the intranet itself, right? So here there's a lot of very good stuff. In particular, I think terminal discharge checklist that we have here is very comprehensive and provides a lot of the things that sometimes we forget, because there are quite a few things to plan for if a patient is being arranged for terminal discharge, right? Okay, so the next thing is actually this GAP tool, or what we call the Goals and Preferences tool. This has been around for a few years already, but we find that the take-up rate has not been fantastic, so we like to emphasize on this. So we have been trying to sort of increase these conversations around patients' goals and preferences around their healthcare at an earlier stage of their journey. And of course, the formal way of doing this is advanced care planning in the what we call the preferred plan of care, right? Which is the ACP discussion that happens usually in the hospital type of setting for us, right? Very often we have conversations with patients about things like that, but they may not amount to a full ACP discussion, right? So it can be actually quite an extensive discussion But and we may even have gotten the ACP coordinator down there as well. But up to the last moment, they just say that, oh, I don't want to sign the document because it feels like a very formal thing, right? So in those types of settings, we will, now they have these goals and preferences too, where if you try to create a new note on the patient's CDoc, it appears as the first thing down there. Because they very sneakily titled it "Ask About the Gap" with an A, so apparently the alphabetical thing puts it to the top, right? So, and this is a free text entry that just allows you to put in whatever you have talked about. And the nice thing about this is that for subsequent care providers who try to put up a new gap tool, it will auto-populate with the previous discussion. So there's no need to kind of search for a lot of search family and then search conference and then search patient update or this kind of comms or this kind of thing. So it's a way of communicating previous conversations about goals and preferences. So this is one of the nice things. Okay, Jermaine, I think in this part, I'll just quickly wrap up about the community services. Yeah, so we also wanted to share a little bit about the community-based palliative care services. And this one, again, I think in the interest of time, I'll direct everyone back to the SGPAL ebook, where they actually have one of the items there on the local palliative care services that are available, right? So you can see here, they have a short write-up on the inpatient hospice, on the palliative home care services or home hospice. And in all of them, they actually go through things like, what is the prognosis that we're talking about when we are referring patients for these services? What is the cost of home hospice? And what patients are appropriate for this kind of thing, and so, right? And also even things like caregiver services, bereavement support, there are things like that sometimes we don't think enough about as well. Okay. So just to wrap up here, I just wanted to share a little bit about the work that has been happening for us. And I think in a lot of ways, yeah, I'm not a palliative physician. And I think, lucky, I think Woon Chai is here to share a bit about, to give some kind of expert input to hold this whole thing. But it's something that, of course, I have believed in quite strongly for the longest time. And I think that the reason why I'm actually giving this session and what we are hoping to do in some of the work that is ongoing in NUH is this whole thing about all of us becoming palliative care practitioners, right? I believe quite strongly that the future of improved end-of-life care is not going to happen when we have more and more palliative specialists or better and better, resources available or more money and things like that. But it's when primary care practitioners and generalists start to deliver better and better end-of-life care. And when we take responsibility for the patients under our care to deliver the best possible care, So I think just to put up this thing, we've recently started this thing, which is we term the end-of-life care plan, right? When patients are identified to be of a very short prognosis, we have piloted this in one of our wards in NUH in 42. And this is basically where a certain template that looks like this takes the place of the normal morning round entry. Back to the documentation part that we referred to earlier, what we're hoping is that for these patients, the paradigm that we approach them with in the morning when we come and assess is no longer, okay, I need to examine the heart, the lungs, copy and paste the plans from yesterday and things like that. But instead, we want to put up all this information straight up here. So to remind us about the things which we should be discussing at this stage. So the CCOD, the preferred place of death, ICD to deactivate that where relevant, and the care form to importantly to put that up. Okay, and essentially the morning round entry will be in this template, right? So instead of the usual subjective thing, we have a symptom assessment. Plans will be in these categories here. So to rationalize medications, put up the right things for symptom management, to rationalize interventions like NG tube, IDC, blood taking, vitals monitoring, and also communication with the family, which we think should happen very regularly for patients like that, right? So, and I think just one last slide here to show up a little bit about the heart behind all of this work, right? And I think you know, I find the reason why I think this is so important for us is because for these patients that are dying in our wards and under our care, this is the one chance that we have to make it as good as possible for them. And so for those of you who may not be familiar with this lady, this is Cicely Saunders. She's a lady who was credited essentially with starting the modern hospice movement, right? So in terms of defining palliative care, what it is today, right? And she, interestingly, I think, okay, not to take too much time, just 1 minute, right? She actually started off not as a doctor, but actually as a social worker. And then after that, she became a nurse. And after that, at the age of, I think, 40 plus, she became a doctor. And you know, for those of us who are worrying about taking time to complete our training and things like that, I think she's an interesting example, because she really is someone who left a very lasting legacy after that about how palliative care has been shaped to be today. And she has a few very, very nice quotes, right? And these are two of my favorites, which she said, you matter because you are you, and you matter to the last moment of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die, right? So I think that's very much the heart of the palliative care part. And the second part is how people die remains in the memory of those who live on. I think these two phrases capture very nicely why we want to do everything we can to make care the best possible for patients like that. Right? Okay, so I've gone a bit over time, but thank you very much, everybody. And feel free to email me if there are questions or any comments or anything that we can do better for the next session. Thanks very much.